welcome everyone to State Chess Conference. And it's a real pleasure. We have a special speaker today. I think many of you know Drew Harris, and I'm going to be extremely brief because he has much more to say that will be educational, useful than I do. So, but he was a fellow here, graduated, finished about 8 to 9 years ago. I did learn that I hadn't realized he was an econ major at Emory before a fellowship and as undergraduate, then went to Pittsburgh for medical school and went back to Emory for residency and chief residency. And some of you may remember that he spent 2 years in the Indian Health Service in Arizona before starting fellowship. And after leaving us, he went to University of Virginia and has had, in really a short period of time, been a very remarkable career, and is, at this point, probably has more knowledge and experience of co-workers' lung disease than probably any other physician in the US. So it's a real pleasure. And I'm not going to get into how many publications, this and that, but he's published in, I think, the journal with probably the highest impact factor in the US, which is the New York Times, and which is important. And actually, that was an important op-ed piece, because after that, he was asked to testify before Congress. And I watched the video of that testimony, did an amazing job. And that testimony related to the silica standard for coal mines. So Drew's had an impact not just on the local coal miners he's taken care of, but really nationally in terms of the regulations. I will say that, and I don't want to embarrass Drew because he never knew my father, but my father's advice always was to just thirsty from, hold on. I rode my bicycle over here. But anyway, my father's advice had always been to do what you enjoy doing and try and make the world a little bit better place, and things will work out for you. So Drew, more than anyone I know, has followed that advice. And I think we're all very fortunate for that. So welcome, Drew.
Carrie, I will tell you that you drank from my water, so I hope that you're not going to sit for me. I got another one here. This one right here. I'm just warning you if you get the flu or something. It's my fault here. Yeah. Good to be back here. It's been 8 years, I think, since I was sitting where you're sitting, and I'm going to get right into it. I have about probably 50 minutes or so to get through. You've probably seen this slide before. I have no relevant disclosures. And I'm going to share a couple patient stories, and these are a couple of pictures of some of my favorite people who are some in this room. The one with the hard hats was with Dr. Redlick, who's not featured in there, but we went to go investigate the Church Street South apartment complex, which I will not speak at all about, but I spent all of my fellowship talking about with Carrie pushing us in with an industrial hygienist to do an investigation. And Margaret and I walked past this complex, which has now been completely destroyed, which is a good thing. I have 3 objectives today. By the end of this talk, I hope that you'll understand a little bit more about Black lung in Appalachia and understand some of the determinants of health that cause health disparities there. And I fully recognize that that is very narrow in scope and doesn't fully apply to all of y'all practicing in Connecticut. And so I hope that in sharing some of my experiences in the advocacy space, that I can help you develop a practical approach to advocate for whatever it is that you care about. And so I'll start by asking who in the room identifies as being from Appalachia. Where are you from? All right, we'll count it. Anyone else? All right. How about now if I show you that map, which is what is considered Appalachia, deemed by the Appalachian Regional Commission, which was established in the 1960s by JFK to try to solve poverty in the region. Any other hands? Still none. One. All right. Where are you from?
Tennessee.
Which part?
Nashville.
Yeah.
Spent a lot of time between Nashville and Chattanooga. Tennessee.
Cool. Awesome. I think most people think about Appalachia, think about the stuff in yellow, which is what I refer to as central Appalachia, and that's Eastern Kentucky, southwestern Virginia, southern West Virginia, and northeastern Tennessee. And to give you sort of just a little bit more geographic context of where I am and where I work, I'm at University of Virginia, and if you don't know this, the Sabres here, this is UVA, and I drive to these clinics in southwestern Virginia. So this is more west than the city of Detroit. And I'm certainly not the closest university to any of these clinics, and I go once a month to drive there, and I'll talk some about that drive later on. I go there because there's very few pulmonologists that want to do this work, and I'll talk about why that's the case shortly. And so I work in partnership with the Federally Qualified Health Center, and Sandy and I were talking about potential partnerships for FQHCs in academia, which is not the easiest thing to get rolling, but essentially the FQHC pays UVA for my time to go down there to do this work. And this FQHC called Stone Mountain is part of a network of clinics that's funded by HRSA to essentially provide comprehensive care for coal miners who are either currently mining or have retired or are disabled from mining. And a big part of what these clinics do is help people apply for a workers' compensation program. And so I'm hoping that through talking about workers' compensation, if you have any inkling to fall asleep, that I do not push you in that direction. And I'll try to make this as engaging as possible, because I realize that's not the most exciting topic, but I think it's a really important one to talk about. Largely because they're applying for this workers' compensation program, who we see in these clinics are retired, disabled, inactive miners. And so I met at my FQHC where I work, Denver, and this is a picture of Denver. Denver was a Little League baseball superstar, and he grew up to be a high school baseball superstar. He led the state of Kentucky in home runs his junior year of high school, and he was invited to try out for the Cincinnati Reds and had multiple D1 college scholarship offers to play baseball. But life took a different turn for him. This is Denver's dad, who was a coal miner in Eastern Kentucky. And Denver's dad ended up getting diagnosed with black lung and progressive massive fibrosis, got really sick, unable to work, had to leave the mines right as Denver was trying to decide about where he wanted to go for college to play baseball. And so Denver took a different path because his dad was the only person working in his extended family, and Denver entered the coal mines. This is Denver on your left, sorry, your right. And I'm going to talk about what happened to Denver in a moment, but since I'm guessing coal mining is not the thing that you guys think about as much as I do, I'm just going to give you a brief primer on coal mining in general. And coal is found underground. It's the black stuff in this cartoon. It's found in strips, or what we call seams underground. Depending on how deep it is underground, depends on how you mine it. If it's fairly close to the surface, you can literally remove the top of the mountain. It's called mountaintop removal or surface mining. Out west, they have big open pits in places like Wyoming, giant, essentially like quarry-looking areas where they mine. What we see in Appalachia is thin seams under the ground that you have to tunnel through rock to access. And so that's drift mines or slope mines, which you see at the bottom here. And mining now is very much a machine-driven operation. We have these big colossal pieces of equipment that people use to pull the coal off the mine walls. This is called a continuous miner. It's a big drum that spins with drill bits on it that pulls the rock and coal off the wall, that then gets on a conveyor belt system and gets shuttled out of the mine. And so Denver worked primarily as a continuous miner operator. He also worked some at this job, which is called roof bolting. And so when you enter a mine, you at some point have to go into the mine and hope it doesn't collapse on top of you. And before it collapses on top of you, you then drill into the ceiling of the mine these giant steel bolts that can be like 3, 4, 5, 6 feet long to secure it to the rock above the mine. And this is like the most dangerous job underground, which he also did. You can imagine that things don't always work out before you can secure the roof as you start to mine it. And I'm guessing you haven't seen many patients with pneumoconiosis. I didn't certainly see many when I was here at Yale until I moved to Virginia, and now I see a lot of it. This is Denver's CT scan, and so this is him in his 40s, and there's lots of small nodules in his upper lobes that have coalesced into larger nodules. If a nodule is larger than 10 millimeters, it's considered progressive massive fibrosis. And so Denver has multiple areas that show progressive massive fibrosis, or PMF. And so this is Denver in his 40s, and this is a picture of Denver and his family. So he's in the blue hat. His dad is in the red hat. You probably can't tell, but he is wearing oxygen in that photo. He has since died from his black lung disease, and Denver's son is in his dad's lap. And this is Denver a few years later after his dad has passed away from black lung. And this is Denver with his kids. And so Denver now is in his 40s. He's about my age, has progressive massive fibrosis, is intermittently requiring oxygen, has a really hard time getting around in life. And his son is now a baseball star. And it's a difficult story. And I think I like to tell his story because it helps make the next few slides where I talk about statistics about black lung a little bit more human. And when I show you statistics like this that show thousands of minors that have progressive massive fibrosis, which is 100% preventable disease, it becomes a little bit more humanistic way of approaching these statistics. These are two very different populations. On the left are current coal miners. There's a program that currently is funded by the CDC or the National Institute for Occupational Safety and Health that provides periodic x-rays to miners. And so working miners, 5% have PMF. So just think about that for a second. If there were working pulmonologists, 5% of us got a horribly progressive, incurable lung disease just from showing up to work every day, we wouldn't do this work, right? So this is a preventable tragedy. When those studies look at just coworkers' pneumoconiosis, it's 20%. So 1 out of 5 have black lung disease. In the graph on the right, we're looking at retired or disabled miners in this network of HRSA clinics I talked about earlier. And the top line is Virginia, meaning the clinic where I work at Stone Mountain. It's the only HRSA clinic in Virginia, and upwards of 15% of the people that are getting x-rays there have progressive massive fibrosis, which is really high numbers. And so last year we published our experience just with new diagnoses of progressive massive fibrosis in our black lung clinic. And there's more than 1,000 that have been newly diagnosed in the last 5 years. Most of the people we see are older white males, and they're almost all from Central Appalachia. And most have worked long tenures underground, but not everyone. Some are very young when they're diagnosed, 70 or less than 50, and 79 had less than 15 years of coal mine employment. This is a very large number of new diagnoses of progressive massive fibrosis, and it's definitely undercounting. This is just one network of clinics. We're not looking at active coal miners. We're just looking at x-ray diagnoses and not CTs, just because that's what our clinics have the most access to. And so this crisis of black lung is happening for a fairly simple reason, which is the type and location of mining has changed. And we're using machines now where we didn't used to do machines, and we're mining out a lot of rock along with the silica because the seams that we're mining are smaller and smaller, and they're surrounded by rock. And so a couple of studies just to make note of. One is a lung tissue study that looked at autopsies and explants and surgical lung biopsies of people who were mining in the contemporary era, which was defined by a birth year, 1930, anyone mining after that, versus an older generation of miners. And the contemporary miners were far more likely, when they had progressive massive fibrosis, to have silica in their lungs. And there's been others that have studied who's more exposed to silica dust. And this is largely people who work in Central Appalachia in thin seams of coal. And I just put this as an example. This is a thin seam of coal surrounded by rock. And you can imagine if you bring in a big piece of equipment to try to pull out that coal, you're going to pull a lot of rock from the top and a lot of rock from the bottom that generates that silica dust. And that's really what's driving this crisis. And for a really long time, we have not directly limited the amount of silica dust that people can be exposed to in mines. And so coal miners have been exposed to twice the amount of silica dust. They've been allowed to be exposed to twice the amount of silica dust of any other worker in the country, which makes absolutely no sense. And we'll talk some about that in a moment. Are there any fellows in the room? What is the treatment for progressive massive fibrosis? Silence is an acceptable answer because there really isn't a good treatment for progressive massive fibrosis, right? And so this is incurable. It is entirely preventable. When people get diagnosed with this, we do things like help them quit smoking. And if they have COPD, treat their COPD and get them in pulmonary rehab, but we don't have a good treatment for it. And so oftentimes I'm referring people for lung transplants. And so I worked with folks at the CDC to just describe lung transplants with the available data that's collected by UNOS to just show you who gets transplanted for coworkers pneumoconiosis. And this is all the data we basically have about that right now. There have been just over 100 transplants for coworkers pneumoconiosis, and almost everyone is from Central Appalachia where I work. And you can see the trends here, which are increasingly more and more transplants are being done for this disease. This is another suggestion of how severe the crisis is, but it certainly doesn't reflect everyone that I have referred for transplant, the vast, vast majority of which don't get transplanted. And the reason for that is partly because of towns where folks are living that get diagnosed with this. This is St. Charles, Virginia, who was recently unincorporated as a town because so few people live there. This is where my Black lung clinic lives. There's 72 people that live there now. It used to be a big booming coal town, and as coal has gone away, so have all the people that live in these towns. And it's the most rural place I've ever been to by far, including on the Navajo reservation. If you go to the end of this road, there's now an active coal mine that's still ongoing. And this brick building here is the clinic where I work. But it's really hard for people that live in towns like St. Charles to get to a transplant center. And so this is driving time and driving distance to get to the regional transplant centers. It's difficult. These people are often living in rural poverty. They don't have access to people to drive them or reliable cars to get there. And so certainly even getting to one of these transplant centers is a success. And so there's lots of reasons why these folks might not get transplanted, but we don't really know that. And so my goal over the next year or two is to try to build a transplant registry, hopefully partnering with all our regional transplant centers, try to figure out what happens to people when they get transplanted, because we don't have any of that data, and also figure out who's getting denied and why. And so hopefully I'll get started on that in the next few weeks. So that is objective one. And so I'm now going to pivot and talk to some of the determinants of health that impact health in Central Appalachia. And I'm showing a lot of maps. This map is life expectancy by county. The Robert Wood Johnson Foundation puts out this, it's called the County Health Rankings and Roadmaps. You can look it up for any state in the country. The yellow, brownish areas are poorer life expectancies, and the dark green, if you drive across my state, you'll meet people whose life expectancy differs by 15 years. And this same program puts out this schematic that talks about what are the factors causing disparities in life expectancy in the region. And I could talk for an hour about any of these factors, which I will not do, but I'm going to focus on just a few. And the first I'm going to talk about is poverty. And to talk about poverty in the region, you have to also talk about coal again. And that's because many of these towns were built for coal mining. And these graphs show the percentage of energy that comes from various sources in our country. What you can see over time is that coal is less and less a part of our energy grid. And this is being replaced by renewable forms of energy. And I'm going to try to make this as not political as possible, but regardless of who's in political power, coal is going away. And that might change because the current administration does not like wind energy very much and doesn't like solar energy, not quite as bad as they hate wind energy, but to be determined what happens in the next 4 years. But this is largely driven not by politics, but by economics. This is a graph that shows the cost of energy production from various forms of energy over the last decade. And the two lines that are essentially straight down are the renewable forms. They're getting cheaper and cheaper and cheaper to produce, whereas coal, which is in black, has basically stagnated and has not changed. And so as things become cheaper, coal is going to go away. And I think that's largely going to just continue to happen, barring some other change in administration, which obviously is a little bit hard to predict. With the decline of coal comes a decline of coal mine employment. And there was an op-ed in the Washington Post a few months ago that said there are more Cheesecake Factory employees in the country than there are active US coal miners currently. There's less than 50,000. That doesn't mean that there aren't still hundreds of thousands of retired and disabled coal miners that are struggling with their health and living in poverty. And in large part, not the only reason, but in large part because of this decline in coal, there's a tremendous amount of poverty in this region. And so the Appalachian Regional Commission stratifies counties in quintiles. The poorest of these counties is called economically distressed. This is the dark red on this map, bottom 10% in the country for unemployment, income, and poverty rates. And it's basically all of Central Appalachia. So I'll talk about a few other determinants of health. One is tobacco use. And this is a graph showing current smokers adult smokers, everyday smokers by county. And Central Appalachia has like the highest rates in the country. There's some counties in Eastern Kentucky where more than a third of adults are still everyday smokers, which is a little bit shocking. On my very first trip to Southwest Virginia, I was driving to meet the leadership of the clinic where I work now and drove past the Lee County Theater and saw out of the corner of my eye the Friends of Tobacco Festival. And I literally like looked 3 times and then pulled my car over, got out and like took my phone out and took a picture. And all these people are looking at me like, what is this guy doing? And this was like shocking to me. This was 2017. I just left Yale as like an eager new grad, like ready to stamp out tobacco related lung disease everywhere. And there's a Friends of Tobacco Festival. And it was initially shocking until I got to talk to a lot of people and ask them like, what's the deal with this? Like, why is this happening? And Central Appalachia is a place where small tobacco farms have been like the livelihood for generations and generations of families throughout the region. And people celebrate tobacco because that's how they made an income for decades. If anyone's read Demon Copperhead, Barbara Kingsolver's book, there's a lot about tobacco farming in that book. And her book's amazing. If you haven't read it, you should. It's all super well researched, but it has to do with the reality of tobacco growing in the region. And it's really sort of just normalized into the culture there more so than anywhere else I've lived. There are lots of other reasons why tobacco rates are so high. This is the excise tax per pack of cigarettes by states. And you can see New York and Connecticut, it's much more expensive to buy a pack of cigarettes there than it is in Central Appalachia. And there's a lot of data to show the more expensive something is, the less people are going to use, especially in the youth population. And there's tons of CDC data about that. Other factors, psychosocial factors, the unemployment and low education achievements associated with high smoking rates. There is far less access to tobacco cessation programs. I spent probably 3 years trying to get a tobacco cessation program up and running unsuccessfully, just unable to get funding for it. At University of Virginia, where I work, we have, probably a dozen tobacco treatment specialists and lots of resources available to people. There's nothing like that unless they're calling national quit lines, which people are probably less likely to engage with than a local program. And I'll talk tomorrow about behavioral health in coal miners, but certainly the overlap with behavioral health and smoking is significant. So the next determinant I'm going to talk about is opioids. It's hard to give a talk about Appalachia without talking about opioids now. If you haven't read the book Dope Sick, another strong recommendation from me, it sort of speaks to Purdue Pharma and how they decided to market OxyContin to Southwest Virginia very intentionally, because places like Van Sant and Buchanan County, Virginia, are the highest rates of disabled workers, I think, anywhere in the country. And coal mining often is spent this high or lower for their entire career. I have a qualitative project that I'll talk about yesterday where someone who was training future coal miners said, if you're not prepared to work under your kitchen table for 8 hours a day for the rest of your life, you're in the wrong job. So you can imagine pretty much 100% of the people I see have back problems, knee problems, shoulder problems. And Purdue Pharma realized this and aggressively marketed their new drug, OxyContin, to this region. And they did things then that would seem outrageous now, like give free starter coupons to people to get started on these medicines for 30 days. They had drug reps that would get hundreds of thousands of dollars in bonuses depending on prescribing patterns. And probably most importantly is misrepresenting how addictive these products were. And so the end result of that is this. And this is published by Dr. Art Van Zee. Art is the only other doctor that works in the St. Charles Clinic where I work, and I get to stay in his house every trip when I go down. He is a saint of a man who's been doing primary care in this rural community for 4 decades. And he was really the first person in the country to sound the alarm about how disastrous OxyContin was for this community. And he had driven from his small town in St. Charles to testify in the FDA and in Congress, and has been really a national leader getting OxyContin to catch national attention. And so his work here shows these little tiny counties in Southwest Virginia, how much OxyContin is prescribed relative to the rest of the country in the early 2000s. So you can see the rates are like 8-9-fold higher. And then this is the end result of that, which is this skyrocketing increase of opioid-related deaths in Southwest Virginia. And this is not a high absolute number, but when you think like towns like St. Charles have 70 people living in it, that when you get 300 people dying a year from opioid overdoses, that this is like destroying entire towns and communities. And this is a picture of Art, and he looks like this every day. He goes to work before I wake up every morning and comes home at like 8 p.m. every night. And he's also a poet, and I'm going to read to you one of his poems, which he published in the Annals of Internal Medicine about 20 years ago. The poem's called OxyContin. It might have been easier if OxyContin swallowed the mountains and took the promises of tens of thousands of young lives slowly like ever-encroaching kudzu. Instead, it engulfed us gently as napalm would a schoolyard. Mama said as hard as it was to bury Papa after the top fell in the mine up Caney Creek, it was harder yet to find Sis that morning, cold and blue, with a needle stuck up her arm. Top of her class with nothing but the promise ahead until hijacked by the torment of needle and spoon. Sorry. Art was the first person to have medication-assisted treatment in Central Appalachia, and he still does medication-assisted treatment in Central Appalachia, and he has parking lots of people waiting to see him every day to help through this crisis. He's an amazing, really inspirational person for the young people in the room. Just seeing what a rural doctor can do and the impact they can have in the community is tremendous. And this past year, Art was I forget what the term is, but when you have a parade, like the last person in the parade that sits with like a throne and like holds some like, the marshal. So he was the marshal of the Friends of Tobacco Festival, which is quite all right, so the last determinant of health that I'll talk about is access, and I just have one slide to talk about access. So this is the mountain range behind my clinic in St. Charles. It is really rural. It is like ruggedly rural. There's very few roads, and there are not many doctors. There's not many primary care doctors, not many specialists. There is no public transportation. People don't have jobs so they can take sick days to go to the doctor. There is no cell signal. When I drive into this clinic, I get no signal for 20 minutes. There is very little fast internet, and when you do have fast internet, people usually can't afford it. And so things like telemedicine isn't like the obvious solution for these towns. And so access to care is really challenging. All right, so my last objective, I hope, will not be seen as self-promoting. I talk a lot about some of the stuff that I've personally done in the region. I do not like disparities talks where we just talk about problems over and over and over. And so hopefully this will be a little bit more practical for you and give you some pearls that might be applicable to your future careers, especially for young people. So my first pearl is, if it's not your history, that you should learn the history of the people that you're trying to help. And I'll tell a few examples of that. Does anyone know what this is a picture of? It is. Brian Clark says how they used to pay people. It's called Cole Script. And that is correct answer. It's Cole Script from the town where my Black Lung Clinic is. Coal company towns were built for coal mine employees to live and work and go to school. And they were, for the most part, all owned by people who didn't live in the region, by non-Appalachian folks who lived in the Northeast or in other countries who got rich off the extraction of the coal, while the people who lived there were Appalachian, usually immigrants or people of color, and they remained in debt. And they got paid in script, which is fake money, only useful in the company town, not used anywhere else outside of the town. They could basically only spend it at the company store. And they had mandatory deductions for healthcare where they could only see a company doctor. And Lily is an intern with me at University of Virginia. She went here for her undergraduate degree, and her undergraduate thesis was in company doctors. And so I'm very happy that she's at UVA. She's the only person at the university where I can talk about this kind of stuff, and she's actually interested in it. And so it's a pleasure that I share that connection with her. But her thesis basically was that many people believed the company doctors were part of this sort of system of oppression that kept them in poverty. And just an example of this, if someone had a cough or felt short of breath and they went to see a company doctor, the company doctor, by and large, would not say this is black lung. They would say this is asthma, like here's some medicine for your asthma, go back to work kind of thing. And this is the way that outsiders and the skepticism for people that come in to take care of folks as a healthcare provider, the skepticism sort of magnified. And before I share a more recent example of that, I have to tell you a little bit more about workers' compensation. So bear with me for a minute. If you are a coal miner and you are sick from black lung, you are eligible for workers' compensation, which is a very small stipend, $700 a month, and health insurance to cover your lung disease. Most people who have black lung are not sick enough to get that benefit. To find out if you're sick enough, you have to go see someone like me, who puts you through a pulmonary function test, a stress test, a x-ray, and an exam. And so there's pretty strict criteria with a little bit of wiggle room to make that determination. If I say someone is sick enough and should be compensated with federal black lung benefits, the person who would have to pay that benefit is the coal company or their insurance company. And so that benefit covers health insurance with no cost to the coal miner. And so if they needed a lung transplant, that benefit would cover every dollar of that lung transplant. So you could imagine that the coal companies do not want a lot of people to qualify for benefits. And so they fight to help to try to prevent people from getting qualified for their benefits. And the way that they fight is if I make a determination, they can then hire their own doctors, get their own x-rays, read by their own radiologists, read their own breathing tests, and then it goes through a legal system where a judge ultimately will make the final decision. Usually these cases are agonizingly slow. They take 3, 4, 5 years to be settled. And the judge has to weigh the evidence. And if a judge is looking at a radiologist report from Johns Hopkins, who's the premier world's expert in reading chest x-rays, versus Norton Community Hospital radiologist Kathy DuPont, whose CV is 4 lines because she's not in academics and doesn't care, the judge is going to weigh more towards the national expert about what they think. And so the black lung radiology unit at Johns Hopkins, up until 10 years ago, was getting paid by company doctors to do company exams. And this is a headline from an investigation from 10 years ago explaining how the head of this program, who's Dr. Paul Wheeler, said that he never saw progressive massive fibrosis in like 40 years. And just for some comparison, this is data from the investigation that came out from this program. The Hopkins radiologist not once out of 1,500 x-rays saw pneumoconiosis and got paid $750 per x-ray. And so if you do that math, it's over $1 million. And by comparison, we pay our radiologists the going rate, which is about $50 or $60 an x-ray, and about 80% of the time we see pneumoconiosis. And so, this is like, this is a crime. And like, to me, this is not just about like a radiology report. This is about someone getting health insurance or getting access to a lung transplant or inhalers or pulmonary rehab or whatever, or not having access to any of that stuff. And so if I don't know that history and I show up from University of Virginia with, a non-Appalachian accent and hair that's 3 times more voluminous than anyone else they've ever met before, they know this history of weird academic doctors doing things that aren't trustworthy. They're going to look at me like, what are you doing here and why should we trust you? And so I have to approach my relationship building knowing that it's my job to earn their trust, which is how I approach getting started. And I started with, how can I help? And so I showed up to this clinic, which is the actual clinic that used to be a hardware store. And so this bricked up building was the entrance to the hardware store when this was a company town store. And I basically said, like, what do you guys need help with? I have no other agenda other than that. And they took me upstairs to this building, which at that time was totally unfinished, and said, we're applying for this federal grant, this HRSA grant. And one of the things we need to check off all the boxes for this grant is a pulmonary rehab center. And is Carly Rochester here? She's not. All right, good. So this is what I did when they said we want a pulmonary rehab center. It was like, well, all right, like, good luck with that. I did nothing with pulmonary rehab and fellowship. It was not what I wanted to do. I was ready to like diagnose and treat. And I toured the building and then went home and did some soul searching. And the end result was that this was what they wanted. This is what I would then spend the next 18 months doing, which was basically learning how to build a pulmonary rehab program. And so probably talked to Carly, I don't know, 30 times in that 18 months. And she really helped me develop this program. And it's now a small program, but an awesome program. And Stone Mountain received $5 million for their HRSA grant. And I had this much to do with it, but I did play a tiny role, which I think helped me earn some trust in the community because I did what they needed, not because I had any other agenda, right? All right, so my third pearl is it's okay to make yourself a little bit uncomfortable. And I showed you a map of the distance between where I live and where I work. And so I do this drive once a month. And I totaled the miles 6 months ago, and it was about 75,000 miles of driving. I've been through a lot of books on tape. My brother thinks that the state ends here in Virginia Tech, having not been past here. It goes on forever. It is like a very long commute. And sometimes this is like January and it's dark and it's snowing and it's not what I feel like doing. But when I get there, it's worth the drive. And so I think being uncomfortable is okay. And the reason why, one of the reasons why nobody does this work, why there's no other pulmonologists lining up to do this work, are several fold. One is, it is boring and monotonous. And I will tell anyone that asks that. You know, when I do disability exams, I'm like a robot asking the same questions over and over and over that I have to ask because it's very standard and structured. And I have to interpret like the breathing test and the x-ray according to very algorithmic stuff. It doesn't require a lot of brain power, except when I have to fight against coal company doctors who are getting paid to say someone's not disabled. And then I get to consult people like Brian Clark to help me decipher the physiology nuances to see is something acceptable or repeatable, and should I say that this is a valid PFT or not because the coal company doctor did not. And I probably have called on Brian, I don't know, 50 times in the last 8 years with questions related to like physiology stuff to make my arguments stronger. And it feels good when I can help minors win these cases because I use a little bit more science and background to fight their arguments, but it's legal. And so I'm constantly being deposed, and most doctors do everything they can to not be deposed. And I sort of walk into depositions like expecting this to be the outcome and sign up for that work. And so like I have to show up in Mingo County to do a deposition against 3M lawyers. 3M is a $50 billion a year company and a Fortune 500 company. And guess what? Their lawyers are amazing. Like they know more about pulmonary physiology than anyone in this room combined. They can cite every paper and every word that's ever been written about black lung. And so like, I need a good night's sleep before these depositions because they will pick apart everything and anything I say. And at this point, I'm like used to it, but like nobody's lining up to do that work, right? It's not exactly fun or glamorous, and like I don't get academic credit for that. Nobody sees me doing that. It's just like useful for people because they need advocates. So my next pearl is that publishing can be powerful. And to do that, I'm going to introduce another story. Let me just check time here. Oh, we're good. Paul is now a good friend. He's the first coal miner that I think in Kentucky that's been invited to a bar mitzvah, which was my son's last month. Paul worked for 7 years as a roof bolter in Eastern Kentucky. And this is Paul's CT scan, which is not subtle, right? Like you don't have to be a NIOSH certified B reader to see that he has a large spiculated right upper lobe mass. In someone who had only 7 years of working in coal mines, this was thought to be cancer over and over again. He had 2 lung biopsies because people still weren't convinced that this was cancer. This wasn't cancer. And his biopsies only showed what's called mixed dust pneumoconiosis, coal and silica in this giant lung nodule. And he had all these other small lung nodules too. That was all just black lung. And when I met Paul, he had applied for his federal black lung benefits 3 times and each time been denied. And it took probably 6 or 7 years for that to happen before I met him. And so what am I going to do differently than all these other doctors that have tried to help him? And everyone else had access to his biopsies and his CT scans. And the counter arguments were kind of infuriating, which was that he only worked 7 years as a coal miner, which people thought at that point wasn't enough time. And so I wrote his story up in the Lancet and published it and submitted it with his next application. And this is the best thing I've ever done in my career, was help this guy qualify for workers' compensation. I promise you, sitting as a fellow in 2014, I would never have expected myself to say that, but like, he now has access to whatever he needs for his healthcare, and he doesn't have to pay $1 for it. And it's life-changing for him. And the picture that was circulating on the flyer was meant to be a picture of me and Paul, but someone cut it out to just look like me in camo, which is totally weird. But now you have some context to see why I included that photo. Paul took me riding through the mountains of Eastern Kentucky in his ATV in the nighttime. And the one good thing about my mom passing away 5 years ago, she wasn't alive for me to tell her about this experience, because as a Jewish mother, she would have freaked out. But we both made it back home safely, and he's now become a really great friend. And my role in the benefits program is very small. So again, I don't want to like you to come out from this talk saying like Drew's very full of himself. I do very little and only work on a very small number of these cases. I have people around me, there are 30 people work at this clinic, and their whole job is to help people navigate through a very complicated federal black lung program. And there are nurse practitioners and respiratory therapists and nurses and what's called legal aid representatives, which are people that know all the black lung laws that can basically function like lawyers, but not charge them any money. And so they go through our program not having to pay any legal fees. And we're like orders of magnitude larger than any other black lung clinic in the country in helping people get awarded these benefits. And so, 262 stories like Paul, people struggling through a very complicated program to get awarded their benefits. So next pearl, only have 2 more pearls, is engage with professional advocates. And I will especially direct that to the young people in the room. This is how I envision my relationship with Gary Ewert, who is Chief of Advocacy and Government Relations at the ATS. Gary his whole job is to help ATS members be good advocates. And so if you approach him with, here's what I care about, how can I what should I do next? He will help you. This is not something we learn how to do in fellowship or in residency or whatever. And so I talked earlier to talk about how silica dust is driving this epidemic. And Carrie mentioned at the intro that there was new federal regulations that were put out after decades of advocacy by lots of other people before I even got involved in this space. So that now what's being proposed is that coal miners are no longer allowed to breathe in as much silica dust as they once were, which is great. But there were tons of loopholes with this law that needed to be tweaked. And so Carrie mentioned the New York Times op-ed, which I wrote. I also testified in front of federal regulators to give them my feedback about why this proposed rule was not good enough. And part of that was wearing a P100 respirator, talking about why nobody can work with a respirator on while they're coal mining. And I wouldn't have known to testify without Gary Ewert's input at the ATS. And I wouldn't have felt comfortable knowing that I could publish an op-ed in the New York Times without Gary's input and sort of shepherd me in that direction. So again, this is not meant to be a story about me. It's meant to be, if you engage with ATS professional advocates, that you can do things that are actually impactful. And that led to, as Carrie mentioned, being invited to testify. This is me sitting next to Cecil Roberts, who's the president of the United Mine Workers Association. And he and I got to share stories and give senators the stories that they need to learn the statistics that I showed you earlier and to see what the problems were with these regulations, see what the problems are with the Black Lung Benefits Program that I just talked to you about. And more recently, let me back up and say, you might be wondering that I work in Central Appalachia, this is essentially Trump country, are all of these government cuts affecting Central Appalachians, where literally 96% of Lee County, where I work, voted for Trump. And the answer is that these government cuts are affecting even sort of the heart and soul of Trump country. And one example of that is these mine safety offices. And so last week they announced that 30 mine safety offices are closing. They're canceling the leases, which it's already a broken system where they don't have enough mine safety inspectors. And so if you partner with professional advocacy organizations, in this case, it's an organization called Appalachian Voices, they will spoon feed you how to do effective advocacy. And so they literally like give you a script to say, here, call this person or send this person an email and write this, and then put whatever addition you want to put in it, which like, it makes it easier, you know, who to call, when and how. And so I did that. And then my senator, Senator Warner's chief of staff, called me the next day, and I talked to him about this for 20 minutes. And so at least he's hearing about it. And he said I was the first person in the state to call him about this, right? Like this is, everyone is so defeated right now that nobody knows like what to do. And there's a great CNN article from a few days ago that says basically all the things that people have successfully changed in the government in the last 6 weeks just from yelling about it and bringing attention to it. And so it is difficult times to get things that we all care about in public health accomplished. But I think if you don't do something, there's zero chance that these things will get changed. And probably these offices are still going to close, but maybe not. And at least I can say like we're going out with a fight even if they do still close these offices. And so my last pearl is about elevating others, and I'll stop talking. And tomorrow I'm going to talk about mental illness in coal miners, which is what my research is involved in now. And this relates to Paul, who I shared the story of earlier. I mentioned he worked for 7 years as a coal miner. But I didn't mention was that he left the mines because while he was roof bolting, this is him roof bolting, a huge rock like a boulder fell from the roof and hit him in the head. And he was unable to walk for 18 months and had refractory seizures for a long time, was in the hospital for a long time. And he became very withdrawn and depressed and unable to work, unable to provide for his family, and ended up really just like disconnecting from everyone and everything for many years before he recovered some. He can now walk easily and became a church pastor. And a few years ago, there was an accident in a coal mine that affected one of the congregants in his church. And a tree fell and crushed a truck and killed a coal miner. And sitting next to the coal miner was someone in Paul's church. And this guy became withdrawn and depressed and stopped going to work and stopped going to church. And Paul drove to his house to talk to him and said, like, you know, you have to talk to someone about this. Will you talk to your doctor about it? And the guy said, like, I don't feel comfortable talking to my doctor. He doesn't know what I've been going through, but he does talk to Paul because Paul's been through it, right? Like Paul is a miner. Paul suffered this horrible tragedy and trauma. And Paul is able to counsel people in ways that I am completely unable to because I have not experienced all the things that these guys have experienced. I'm not even from these towns. And so I'll end with this quote from Paul, which is, if we're here on this earth and we have a purpose, we need to find it, accomplish it, and make the world a better place. And I think that fits well with Carrie's dad's sort of way of living, which I'm pleased to hear that intro, Carrie. And so that's my last slide. Thanks for listening.
Thank you very much. Open it for the questions. Margaret, you want me to yell? You want me to yell?
Drew, thank you for that wonderful talk. It's so great to see everything you've been doing. But maybe for the fellows in the room, can you just say a brief word about how you talked about this one piece of your career, right? But can you just say something about how you combine that with the rest of what you do in your academic?
Yeah. So I could answer that in a couple ways. I think the practical answer is at this day and age, everything you do in academics has to be paid for, right? Like if you're not grant funded, you have to find other ways to not just be in the MICU or seeing patients in clinic. And so I spent a while trying to develop relationships before having a contract between the federally qualified health centers and with my university, which then buys my time to be able to free that up. But most of the time I'm in Charlottesville doing other things. And so, you know, it's funny to say things now and wonder what's being recorded and like at what point I'm going to have like Doge come after me. But you know, most of what I've been focused on is in sort of the health disparities space. And so I work in an APD for the residency program, running a health equity and advocacy track. And so 5 or 6 residents a year like choose to go down this pathway to do stuff advocacy related, have their own projects totally separate from black lung and coal mining. And I work in some satellite clinics at UVA, which are in the mountains. You know, they're 45 minutes from Charlottesville, but they get really rural really quickly. And so I've sort of, just because I've moved to Charlottesville, I've sort of developed an interest in rural health just because it's so rural around where I live. And so that's sort of the focal point of my career now, which I think is a Doge safe word. I can be rural health interested and I'm not be worried I'm going to get put on all this anymore. Yeah.
Great to have you back, and thanks for this great story of the work you've been doing. I wanted to ask you a little bit about the statistics you were showing about the increase in the incidence or prevalence of silica-related black lung disease. To what degree is that? I think you're kind of highlighting the mechanization and how that's sort of changed the way that the coal mining's happened. But to what degree is it also related to sort of more awareness and more diagnosis? And could you just also say a little bit about other occupational associated lung diseases besides silicosis? Because I know in other parts of the coal mines, there's different types. Thanks.
Good question. So I showed up at the Stone Mountain Clinic after a JAMA publication was already published that described the amount of black lung they were seeing in 2017. And when that publication first came out, more people, it got national press. And so that like flooded this clinic with people seeking out x-rays, wondering if they had disease. And so I think you're right. Some of this is like increased recognition that, oh, maybe I should get screened. I'm short of breath. Maybe I have black lung. And so I think there's some of that. There's still really poor participation in the surveillance programs. It's something like 20% of people who are eligible do these, the co-workers health surveillance program. And so I still think it's underreported, even though there's more and more people coming in for x-rays from that regard. And then, you know, occupational lung diseases, the term that we use is coal mine dust related lung disease, which is kind of a mouthful. And so coal and silica dust independently of smoking can cause emphysema and COPD. And so that's a really underappreciated part of occupational disease in coal miners, and one that company docs often dispute. But there's autopsy studies that quantify how much emphysema someone has in non-smokers and account for smoking. And still, it's clearly an independent risk factor. And so what we see the most of is emphysema and COPD, in addition to the nodular coal-workers pneumoconiosis. And the other sort of fibrosis that we see looks like UIP, and we call that dust-related diffuse fibrosis. And that is also a disputed term with company docs, and something that I often have to talk to lawyers about. But coal dust can cause UIP pattern fibrosis. That's often slightly less rapidly progressive than what we would think of with IPF. And those are the big occupational diseases we see. You know, there's diesel exhaust and stuff that can like trigger airways disease, that sort of thing. So I think that the big things we see are COPD and pneumoconiosis. Yeah.
Oh, okay. Why don't I'll go quickly. So wonderful talk, a nice demonstration of how you stick to your core values. You can, you know, do the work you want in academics. And I think, you know, you've accomplished that, or are still working in that direction since you were a fellow, going into dangerous places and being exposed to things and trying to prevent others from doing that. I had 2 quick questions. One is, you know, you said that people can't wear a P100 and work in the coal mines. There are a lot of other technologies that are currently in use with firefighters and divers and things like that, that allow people to prevent, you know, not be exposed to things, and, you know, and communicate, you know, and do their work. And I noticed you know, I didn't see one mask at all in any of the photographs you showed of all of the miners. So the only one I think I saw was you at the congressional hearing, which is probably need to wear it because, you know, there's a lot of exposures there, right? The second question was just in terms of biology and biologically, you know, can you predict in any way who's at risk for getting this? And are there people that don't get it?
Yeah.
And are there ways to predict that so that you can, you know, counsel people that you're at higher risk,
Yeah.
you know, of this? And, you know, is there a phenotype or prediction? I assume some of it could be hereditary, and it looks like coal mining is office runs through families. So you probably see a lot of it in multi-generations, which is what you've shown.
Oh, yeah. Yeah. You know, the last question is an interesting one. And I think it's difficult because exposure levels are so different between people. And like, you know, some people are going to work in like a 20-foot high ceiling and some people are going to work in 24-inch coal. But there are people that work their whole careers that don't get disease. And we're just not sophisticated enough to know who that is yet, but it's a great question. You know, in the ideal world, you'd get screened with something before you entered the mines to say, what's your risk for developing this disease? And could a small dust exposure cause a tremendous problem for you or not? I think for now, we just err on the side of there's no real safe dust exposure, and the least the better for everyone. But hopefully maybe that's the future of dust exposed workers in general. And, you know, there's, it's difficult because currently PAPRs or like better respirators aren't provided by the companies because they're expensive, and they really barely even provide disposable respirators from a mask standpoint. And so only recently have that been like a more widespread phenomenon. But certainly a lot of the guys I see who are mining in the 80s, 90s, early 2000s, it was like if there was one provided to them, they would wear it sometimes in the dust and not all the other times because it's hot and loud and it's hard to talk through those things. But you know, if they had PAPRs and like earpieces and you know, microphones or something, maybe that would be a more reliable way to do it. It has not taken off. You know, I don't know anyone that wears a PAPR in active mines, but that would be like the way to do it. It just is harder to communicate without some sort of assisted device so you can talk. And there has to be constant communication. You know, I'll talk about some data tomorrow just about trauma, but like the amount of injuries and explosions and collapses that happen in these mines, it's like war. And anything that inhibits communication, I think, is what prevents people from wearing it. And it's just not practical for them to be able to talk to each other without, you know, assisted devices that they have an earpiece in or something like that.
So that's about true. You're saying that the companies are providing the better devices.
Yeah. And I think the issue is like, you want to stop, you know, if you look at, there's a hierarchy of dust control, right? And so the first level is like, you want to not have as much dust as you can, that cannot create as much dust. And so putting things like water sprayers on to minimize the dust or have dust collection systems, sort of engineering controls are what should be getting rid of the dust. And then it funnels down to like the last line of defense is a respirator because it's difficult to wear and like the equipment sometimes doesn't work or whatever. And
True. Thank you for saying that. But from an occupational point of view, we do have a hierarchy. We know how to control dust in coal mines. And there's frequently a lack of will, whatever, on the part of the companies.
yeah, and it's more work to have better ventilation. And so like they have these things, they say hanging curtains, which is like directing actual curtains so that there's like clean air coming in and bad air coming out. And like, you know, I've probably had 1,000 miners tell me they hang the curtains when the inspector comes in and then they take the curtains down. And it's just easier and quicker. And, you know, the companies are just like we're sort of driven by RVUs. They're driven by how many tons of coal can they produce each day. And they're sort of held accountable to that. Yeah.
I had an opportunity to go to two of these mines, 3,000 feet down, and there is no way you could wear a respirator all day. In terms of the work and
Yeah.
just.
It's hot and loud.
And there's whole systems of ventilation. I mean, there's been a ton of research and work done on how to ventilate a mine. And so it's a very doable thing.
Mhm. And it is like better now than it was 30, 40 years ago, but like there's still active miners that have pneumoconiosis and PMF. And so it's not like the problem has resolved. Yeah.
Online we have, yes.
We got some.
Yes.
On?
Just
On. Okay. Hi. Thank you so much, Drew. It's good to see you again.
Good to see you.
I had a comment that led to a question, which I think you've answered a little bit already, but thinking even more ideally. So first of all, so heartbreaking to hear your first story about the I forgot the name already, sorry, of
Denver.
the person whose father developed black lung and then he left college to go work in the coal mines and then also develop black lung, and then his father died and now he's, intermittently needing oxygen now. Just the thought of why would you sign up for what you know
Yeah.
what the outcome is going to look like? And I know that's not the question. I know that the answer is all of the social determinants that you talked about and the options that people have and what that community is like. And so my question in terms of advocacy, what would be the ideal solution? And we talked already about like providing respirators, improving ventilation, like that doesn't seem like an ideal solution, and decreasing the amount of silica you can be exposed to or the amount of dust or whatever feels like very small band-aids for a much bigger problem.
Yeah.
What do you see as the still realistic but ideal solution to really eliminate this, because it's so preventable and it's continuing so much?
Great question. Yeah, there's a lot of research going into wearable dust sampling devices that would hopefully tell you in real time how much silica dust you're being exposed to, so that like what's it called? Orange theory, you like have like a screen and like stuff lights up when you're like doing good or not doing good. And you can imagine like a red light comes on when you're in the danger zone, and then you do something different at that moment. And there's not a moment when you're in toxic levels. And I think the first step is to at least reduce what's called the permissible exposure limit, how much silica dust you're allowed to breathe in, make that in line with every other industry in the country, because right now it's not, which makes zero sense. Every other industry is regulated by OSHA, miners are regulated by MSHA, and they have different standards, and like that, it just is insane. And so this I think is a step in the right direction, but trying to fix all the sort of loopholes around it is what I had been involved in. But the long-term solution, I think, is sort of continuous wearable real-time silica dust monitor, so that people know immediately, and then they can do something different so that they're not exposed to that.
Okay, Drew, it's late. I just wanted to say, stop saying you didn't do much. Knowledge is the most important thing. All in all, humans, when they know what's right, most of the time they do the right thing. So that's a very big part that you did. But one thing I wanted to ask you, this is an opportunity also. This is one of the few pulmonary fibrosis that you have a dose and you have an exposure. Like liver, we know now that MASH, for instance, when they control it better, some fibrosis goes back. So I don't know if you have already seen it or look for it. If by a change in exposure, lung fibrosis goes back. The mechanism of silicosis is known really well. Because immunology, we know why.
Yeah.
If it really goes back, it would be a big finding. So let's just see.
Yeah.
Have you seen any going back?
No, there's the opposite is what we tend to see, which is after the exposure ceases, we see progression of disease. And that's been fairly well radiographically characterized. I don't know that we have any tissue to like study like what's actually happening, but we see progressive fibrosis after exposure. And that
it's possible. So the liver is much more than the body, but it's possible that lung could be refined.
We are over time, but Richard Mathay and Vahid Mohsen both asked questions online. Vahid asked, great talk, Drew. Can AI-assisted interpretation of chest films flatten the playing field?
Yeah. I'm waiting for that moment. And I think it's really hard on X-rays to distinguish these teeny tiny 1 millimeter nodules effectively. It's, they look like blood vessels on end. And so I think for early disease, X-rays might be too difficult, but CT scans certainly. And we're headed towards CT scans in the next probably 5-ish years. They do that internationally now, but not in the US.
And Richard asked a question that I'm not sure you have an answer for, but in terms of your career and that of your colleagues at UVA, has UVA been penalized with loss of grant funding such as Columbia? And is UVA one of the 60 schools on the current administration's list of schools under consideration for decreased funding?
Yeah.
Yes,
Yeah.
exactly.
At the start of your question, the answer is no. By the end, it was maybe. I don't know. Yeah, no. We are on that list, though. We're on the 60 university list.
Yes. So Drew, thank you for a really wonderful, inspiring talk.